I've worked at East Alabama Medical Center for 38 years, been in emergency management for 30 years. I started when I was like 8 years old, and have a bachelor's degree in human resources, and I'm a certified healthcare emergency manager, and a member of the International Association of Healthcare Safety and Security. I'm responsible for safety and security at our organization. Senior member of the National Crisis Prevention Institute. I'm a certified instructor of nonviolent crisis intervention. That means I can teach you how to take care of aggressive and out of control people. Mainly it's just being nice, but that's another story. Professional relationships, tied really closely to the Lee County Emergency Management Agency. We work really closely together. I go to places where people say, well, the folks at the Emergency Management Agency and the hospital and the police department, they don't even like each other, but we all have lunch and we have drills together and we have a real good close-knit relationship. The River Region Healthcare Coalition, again, I want to thank Cindy and Tim for their leadership of that coalition. I was the first chairman of that coalition and served for about 3 years, and we all still work real closely together. University of South Alabama, the Advanced Regional Response Training Center, been affiliated with them about 10 or 12 years, and David Wallace says it's 15 that I've gotten so old I can't remember what year was which, but served with them to help design the Certified Healthcare Emergency Management certification process, and of course I hold that certification. Currently working on the Crisis Standards of Care work team on behalf of the Department of Public Health. So I'm going to do a couple of things today. One of the things I'm going to do, I'm sure, as Cindy said, most everybody in here is the choir, and you know all about the Strategic National Stockpile, but there might be a couple of people who might want to know a little bit more, so I'm going to highlight and touch on that for just a second. And then I'm going to talk to you a little bit about what we've done as an organization, as healthcare, to begin to prepare ourselves as a closed pod. We're not quite at 100% yet, the way Auburn University is, and I'm going to enlighten you about that. But the brief about the national stockpile is for those of you who may not know a great deal about it just yet. And this, as soon as just the right clicker is going to make this work. So how would emergency management and public officials handle a catastrophe that tax local supplies of vaccines and medicals? Obviously, the stockpile consists of warehouses of certain medicines. There's the underlying premise that the Strategic National Stockpile will primarily respond to chemical, biological, radiological, and nuclear events, and that's changing. The exact number of warehouses, we don't know how many we have. We don't know where they are. We just know that they're large enough to respond to several large cities anytime that we ever needed them. They're located throughout the country, and of course there's always things going on to change out the medications that send them. The constant quality assurance is real important. The big picture, overall, it's just part of the overall plan for getting supplemental emergency assistance out. The original goal was to respond to chemical, biological, and radiological and nuclear threats, but that's been expanded. Just like emergency management everywhere, we're going through a period of wanting to be all hazards, everything. The list of what goes on in the national, or what goes into the national stockpile, is always based on whatever the most current threat is. What's going on? What are we learning from intelligence? But it changes all the time. It's responsible for the middle part of the process, and I think that's real important for everybody to understand. They maintain the inventory. They make sure that we can get it when it's needed, but the stockpile's responsibility actually ends when they distribute it to the people who need it next. And so the critical inventory, they say there's about $7.5 billion in inventory there. There's about $500 million set aside each year for annual appropriation. And the experts decide what needs to go in it. Again, it's based on what the current threats are, what the current potential outbreaks are, what the terrorist threats are, what do we need. They make sure that we get it in there. And the program works with commercial vendors, like we were talking about Walgreens earlier, CDC was. They work with commercial vendors to provide some of the material, sometimes in response to emerging threats, but also obviously to large vendors, large pharmaceutical companies that works with that. And of course, one key aspect of the stockpile is always quality assurance. They are constantly making sure there's no expired medications. They are making sure that we have the most current and up-to-date medicines there, so that if there's some kind of disease outbreak or a threat, it can be responded to. It's a very complex process. The materials can only be effective in an emergency if they actually get to where they go. And I think if I got three things to really point out, it's the 3Ds. The delivery, or getting the medicine from the stockpile to the local areas. Distribution, which means getting them to the specific areas of where it'll be used. And of course, dispensing, which is what we'll do at a closed pod, making sure that it gets out. Process starts once local and local resources and state resources are exhausted. So the outbreak, everything just doesn't shoot down to start with. There's a process, but the CDC uses vendor-managed inventory that can get to an affected location within 24 to 36 hours. And I think Cindy hit on enough a little bit earlier on that I don't need to spend a lot of time on that. So what are we doing at East Alabama Medical Center? Why is it important to us to be a closed pod? We're a 340-bed regional referral hospital. We have about 3,000 employees. And that's a little bit of an outdated slide. We actually have the Lanier Hospital, which is located about 30 miles from us, and we've added some people to that. But Lee County itself, this hospital is the second largest employer, so you see we have a lot of lives at risk, and that's why we think it's so important to be a closed pod. And we provide some pretty high-level care, so if you want to think about it, who are some of the people that it's most critical to be able to be well, to take care of people who are sick, other than a healthcare organization? So what we've done is we followed the format for applying to be a closed pod. We collected all of our organizational information, our numbers of employees times 2.5 to determine what our numbers of lives that would be at risk in an outbreak. We've already worked with Cindy. We've been working closely with Cindy for longer than I would like to admit. But I love Cindy, but it's taken me longer than I would have liked it to have taken to be where I'm at right now, because Cindy's a great leader. But we've identified our language interpreters. We've located enough space. We've located 3 different spaces. We've developed a system so that employees and their family members can come by and pick up their medications, and we don't have drive-through like Robert does. Ours is a little bit of a simpler process, but of course it's really important for us to be able to develop employee medication, pick up tracking, security management. When the first gentleman went over his thing, I go, oh, I'm not prepared to do that. We do have a security manager and we do have a security team, but I realize how big that process is going to be, so I made lots of notes about what I need to go back and take care of that. We've done pretty much everything that we need to do. We've assigned owners. We've identified the building. We've pulled all the forms that we need. We've set up staffing. Staffing is extremely important. Who's going to run the thing? Who's going to take care of it? It's not something you'll get done in a 7 or 8 hour period. And so we've identified 3 different places that's large enough to conduct dispensing operations. We've developed all the forms that we need. We've got a medical director. I mentioned the security manager a little bit earlier. We're currently working on pre-event education. You can't surprise that number of employees without planning ahead. We've developed most all of the list of all the supplies that we need. And being a hospital, we already have a lot of that, a lot of the supplies needed. And of course, having a very busy disaster plan, we always have an activation system. So if there's an outbreak, we automatically know who we're going to communicate with. Somebody mentioned earlier how important that public relations is, and we've got him on the team along with us to go ahead and decide. And we go back all the way to when we invented our pandemic influenza team in 2000. Some other people that have been around for a while will remember those years. And we were able to go back and pull a lot of this from out of there, fortunately. And this is just a list of places that you have to have. You need a symptomatic. And you know what? Tamiki's done my homework for me. If you just look around the room, that's what's on this slide. We have to have triage. We have to have first aid. We have to have a clinical supply area. We don't, well, we're working on the express dispensing. Obviously, it starts with intake and registration. We have a drug utilization review. Having a pharmacy inside our hospital benefits us because when somebody comes through to get whatever medication or whatever injection that this particular outbreak is requiring, a pharmacist has got to sit down and look at all the kind of medications they're on, look at any kind of specific illnesses that they've got, and help them cross that bridge. Family compounding. If it is injections, then you are going to get more than just a leader of the household to come pick up what you got to have. Functional access needs, special needs. If people have language barriers, if people have disability barriers, and particularly need things. Again, we're working on the express dispensing. And we think we got that pretty much covered, but I don't want to, you're going to see I give myself a score a little bit at the end. And checkout, of course, we do have a checkout done, and that's going pretty good. First aid, we've got a place for first aid. People are going to, show up that aren't well, that need some medical attention. There's going to be a need for individual counseling, mass counseling. You'll have people that come in that aren't just there to pick up medicines, that they're afraid of what's going on. They're excited, they're scared, they have children, they're worried. Well, we have a team that'll take care of that. And a lot of that's done from the family and support staff area. We have social workers there to help with that and help people with their fears and their needs. The clinical supply area, that is real important. Obviously, after we get our clinical supplies, our medications, and we'll be getting that. It'll be drop shipped to EMA. We'll send our security team over to pick it up. We'll take it to this area. We have a warehouse that we'll keep everything locked up in, but the day's supplies will be carried over, and you'll see on the makeout, the markup that I'm going to show you in just a second that we keep that very secure. Incident command. Not any different from any other disaster, except with some different people that'll need to be involved. You'll have your typical administrators. You'll have your supply people. You'll have your pharmacists. You'll have all the different people that make up a typical incident command center, making sure everything's going on and taking place as should. A break room. Well, why is a break room important? Well, everybody in here that's ever been through any type of disaster, and if you're an emergency manager, what's one of the first mistakes we make? We work too hard, we work too long, and we get exhausted before we call somebody else in to take care of us, and then we can become ineffective. So we've got made sure that we've got a break room to take care of that issue for everybody. This is the first building, and we've picked three, and I'm only showing you this one. This is actually our employee wellness and our employee care center. We call it, it's kind of our dock in a box for employees, but it's a large building, got lots of treatment rooms, bathrooms, conference rooms, pretty much everything that we need to develop our closed pod. Now, our closed pod doesn't look exactly like everything in the room just yet, but obviously you'll notice everybody comes in the entrance. And there's a big parking lot out there, and of course we have plans for a security guard or two to be out there to escort people in to sort of modify the process. First thing is intake. Find out as much as you can about the person who's coming in, what their needs are, a little bit about them, a little bit of information. Medical triage is right next door, and then they get sent out to registration and forms and directions, a little bit about some information. Talk to them about going through the treatment rooms, and you'll see we have 5 treatment rooms. And in the back, you see the staff comfort room, of course. And over on the right-hand upper side, you see non-secure supplies. And in the top right, you see a place for question and answers. And you also see another place in the far left, a place for comfort, questions and concerns. So when the people go through registrations and forms, and then when they go through pharmacy counseling and they get the UR done and all that, then they go through the treatment rooms, and then, of course, there's 2 exits for them to go out the door. We know that's just our very first shot at it. We know we've still got some room for improvement. We've still got the other 2 buildings that we've got to mark up and create this same plan. Fortunately, we're not as large as Auburn University, and we've got a little bit of room to grow. And but I did want you to know from a healthcare perspective, this is kind of the flow from the strategic national stockpile all the way down to the end user. So you've seen a little bit about, you've heard a lot about the strategic national stockpile. You've seen what we do as healthcare to try to prepare for any type of outbreak. And so anybody in here who your agency or your company or your affiliation has not been involved in a closed pod, it's pretty simple. And I'm just going to flip through these slides easily because this is the point that you go through in order to become a closed pod. You got to get in first in touch with your EP coordinator. A little bit of information that he or she will need on you. Ask questions. Ask you to contact the EP coordinator again and provide this information. You'll have to have medical personnel available who can legally dispense medications. It's not as easy as just because I go to this big church and I want to do this. A church can be involved in it. A faith-based company can. Probably would use parish nurses. You probably would use a physician, but there's a lot of moving the direction of large churches serving their congregation. You have to have somebody to sign off as your medical director. So hopefully somebody, one of the doctors in the church will do that. Just talks about, they'll ask the question, who will the medications be dispensed to? They'll ask you to define what your family member really is. And then you get a little bit more complicated when you're talking about estimating the breakdown in the following age groups. Ages 65 and older, 18 to 64, and children under 80 pounds, under 18 and weighs less than 80. What languages do they speak? Then, of course, the question's asked, do you have a place to do it? Can you create something where you can track all the medications? And Department of Public Health has that covered all over the place. They'll give it to you. Do you have a security team? Like he talked about earlier, securing the place is real important. There's a lot of morons out there, and they're going to come out of the woodwork. I want my baby to have this, and you're going to have to give it to me. Well, we're a closed pod. They're going to have to be diverted to the open pod. So the more closed pods that you have, most morons even have a job. So hopefully their industry or somebody affiliated with them will create a closed pod. Tells you all the supplies you need, talks about activation, talks about how to prepare to receive and dispense medications, and then you submit your plan to Cindy or your EP coordinator or the Department of Public Health for approval. Then after that, once your plan gets approved and once it gets in place, your next homework is, if anything changes about it, always let your EP coordinator know. So I give us we're about 80% complete, or we have 20% to go. It depends on I think our glass is 80% full, not 20% empty, and that's kind of the way I look at life, and that's the way I do emergency planning. So I want to thank you all for letting East Alabama Medical Center, EAMC Lanier, be represented here today and talk to you guys a little bit about a lot of stuff you already knew, but give you some insight as to what we do.